Okay, so, oh, you did? This is my first semester not being at the lab. I was full time until this semester. We moved to Corpus, so I had to go adjunct. So there's definitely some good potlucks that I've had. So I'm going to do things a little bit differently this time. I'm going to go through the system disorder templates with you. So the fracture, and then we'll do amputation. And then after we've kind of gone through the disease processes, we're going to go through some questions and kind of see what we learn and kind of take it a little bit deeper with some mini case study things. So first we have fracture. And this is kind of vague, I know, because there's different things for different fractures, but for the most part, pretty similar care. So what's wrong with our client? What's fracture mean?
It has some broken, like broken bones.
Yeah, exactly. So we have either a disruption or a break in the bone.
Professor, can we just say relocated is considered as the fracture? Like you go ahead.
I'm sorry, say it again.
Like relocating the joint.
Like dislocating the joint?
Yes. Is kind of considered as the fracture?
No, it's a dislocation, and you might have some deformity, like we might have with a break in the joint or in the extremity, but it's nothing is broken. You just have something out of place.
Mm-hmm. Does that make sense? Perfect. Thank you.
Mm-hmm. Okay, exactly, Brandon. So like a stress fracture is kind of more of a disruption, like a crack, than what I would consider a true break. Mm-hmm. Okay. Say again? Kaylin. Hi, Kaylin. We're just going through the system disorder template for fracture. Okay, so now we are, how do we prevent fractures?
Enough calcium. Yeah.
Calcium, okay, that's good.
Phosphorus, magnesium, and stuff.
Mm-hmm. So for that, I'm gonna put manage osteoporosis. Mm-hmm. Or other chronic diseases, right? Mm-hmm. That might cause a break. We can work on the underlying symptoms and do things like give calcium. Mm-hmm. What's another huge thing that causes broken bones?
Is the patient who is on fall risk.
Mm-hmm. Exactly, so trauma. And how do we prevent trauma? That's kind of hard, right? So we're gonna promote things like seat belts, helmets, to be as safe as we can to avoid trauma as best we can. So risk factors, again, if you're in a trauma, there's a risk you're gonna break a bone. And then if we have a disease process, osteoporosis, or cancer is another one. Okay. Injuries, yeah. Falls is a huge one, especially in our elderly population. They all fall and break their hip.
Yes, that's my grandpa died from that.
Oh no. So I'm gonna do a laboratory test. So really not gonna be drawing a bunch of blood in relation to a fracture. That's not really a blood test process, I would say probably you'd want a CBC, just if we're throwing out tests, just to check our blood count, make sure we're not bleeding too much. If we have a trauma, for sure we're going to want a CBC. And then I just put like related to the underlying. Oh, hold on 1 second. Okay, sorry. My daughter, it's like a magnet when I come in here. My daughter wants me the best. Okay, so where are we? So lab test, not really lab test type of disease process. Expected findings. What do you guys think? So obviously we're going to have to like pain. Yeah, exactly. What are like some signs and symptoms that we would expect?
swelling,
bruises,
edema, swelling.
Swallowing, bruises.
I can't spell whenever I do this. Maybe loss of function, right? Not able to.
How about muscle spasms?
Say one more time.
Muscle spasms?
Yeah, could be. Okay. And then we might expect to see, if we saw an open fracture, we would know for sure that they had a fracture, right? Or we might see a deformity. So when we're examining the area where we think there might be a fracture, it's not straight, for example. If you had like a forearm issue and it's displaced, then we know, okay, there's a deformity to the arm, there's probably a fracture underneath. Yeah, go ahead.
How about loss of distal pulses?
So, I'm sorry, say one more time. I don't know why
The distal pulses on your feet, like if you have a distal
pulses?
Yeah.
Yeah, exactly. So we would be really concerned if we started to have a decrease in our pulses. But I always think about, when I think of open fractures, I think about when I was working in the ER and I was sitting up at registration, and this guy comes in and he's like, "Oh my gosh, my son broke his arm," and we're like, "Okay, calm down. Like we'll take a look at it." And he comes up and we look at the little boy and it's like an open fracture, and we're like, "Oh, okay, yes, he did." But usually parents are, over worried, and it's like, okay, well, we'll x-ray it, we'll see what was going on. But no, it was legit. Anybody could see it was broken.
Wow.
Okay. So they also another word we might use is guarding. So guarding is where we're kind of keeping something from moving because of pain. So if they're guarding a certain area, then especially in the elderly that maybe can't communicate as well, we see them guarding a hip, that would just to investigate further, right? So as far as diagnostic procedures, what's our biggest one? X-ray? Oh, not X-ray, X-ray. That's how we're.
CT scan?
Huh?
CT scan?
Yeah, so X-ray is going to be our main one when we're going to be visualizing bones. But depending on the X-ray, we might do a CT or an MRI. Okay, so let's move on to safety considerations. So what are some things that we need to keep in mind?
Fall risk?
Yep, that's a huge one, right? We don't want them to be falling and re-injuring. So we want to have all our precautions. That's another really big one, especially with long bone fractures.
So, long bone fractures. Let's see.
Is the calcium
The
deficiency?
serum calcium might be increased, but because of a break. But I am looking for if you break a long bone, you're at a higher risk for a fat embolism, right?
Okay, oh yeah, fat embolism, yes.
Mm-hmm.
How about compartment syndrome?
Compartment syndrome? Yeah.
Mm-hmm.
So either a fat or a embolism. Okay, so either vascular or fat embolism. What was the last thing that you said?
Compartment-wise syndrome?
Yep, compartment syndrome. Rhabdo, right?
Yeah.
And then another big one is neurovascular. So our blood flow. Oh, Brandon says DVT. Yeah, exactly. So thromboembolism or a fat embolism. So we don't want to have any kind of decrease in the blood flow to the area. And so that's one of our biggest safety concerns when we're talking about a fracture, is we start having edema, because the body, that's the body's reaction when it gets irritated, right? It starts kind of swelling up. And so as that edema expands, then we have less and less room for our blood vessels to be, and they get compressed, and then we have less blood flow to the area. So we really want to keep on top of our neurovascular assessments in these patients. Some other things that I put, kind of special considerations, facial fracture, there we go. We want to think about, or C-spine, we want to think about our airway. Right, if there's some kind of injury, break within the face, or within the C1 or C2, we can really be concerned about our airway. So we want to have trach equipment at the bedside in case we need to have an emergency surgical airway. So that was a special consideration for that. And then pelvic fractures I'm going to put, just because they are high risk. So whenever we have an injury within the pelvis, there's so many organs there. Think about having broken bones that can poke at those organs. So we can have puncture of the bladder, the stomach, all of that lower abdominal organ that sits in that abdominal area. So, and they're really high risk for bleeding. So we need to be really, really careful with pelvic fractures, especially if they're displaced. Okay, so that's all I really have for that. Okay, so what kind of nursing interventions are we gonna do?
You could do icing.
Possibly. We want to be really careful with icing, because that's going to decrease the blood flow to the area when we put ice.
Mm-hmm.
So usually not on a fracture.
So how about like traction?
Mm-hmm. Yeah, could be. So I'm gonna put, let's see. Traction or pens, and we're gonna manage those and do pen care if we have pens. in our patient, right? If we have external fixation. The big one that I mentioned, we're going to do neurovascular. What was it? Yep. Yep. I'm going to put that in the, here, I'll put this over here.
How about nutrition?
Yeah, nutrition. Exactly, getting all those clutter and area rugs and all the things that I think about that can trip up our patients. Good lighting.
Mm-hmm.
We want good nutrition. We want good nutrition because we want to promote healing. The body's been injured, it needs all the nutrients it can get, a nice, healthy, balanced diet so that it can heal itself. What about fluid intake? Yeah,
fluid.
Exactly. So we want to push fluids so that they stay hydrated, so that we avoid rhabdo. It's another one. So just them staying hydrated is going to kind of help flush out the body. It's also going to help with the possibility of constipation. So whenever we have a patient that's immobilized for whatever reason, so we're looking at some kind of fracture that's going to impair them walking, and they're going to be laying in the bed quite a bit, hip fracture, pelvic fracture, that's really going to impair their mobility. And so we are going to be concerned, we're also giving them opioids, right? Most likely some kind of pain medication. And we put immobility and pain medications together. And if we add another extra bonus of them being elderly, then we really run into problems with constipation. So we want to really be on top of promoting good bowel hygiene, basically. So I'm going to put, I already said nutrition, say we want them to take fiber in. That's a really good question, Brent. So ideally, no, but we have to weigh the benefit versus the risk, right? So if they just absolutely cannot get up, then yes, they're going to have a catheter. But more and more, we're trying to not put catheters because why?
UTI?
Exactly. We want to avoid UTI. So we know that our risk goes way up when we put an invasive line. So we can do things like PureWick. For males, we can do things like condom catheters, trying to avoid that. But if we can't, we can't, and we use the catheter because we want to maintain that skin integrity is really important. Okay, what else did I have for this? Let's see. We also want to know in our assessment, the mechanism of injury. So you'll hear that term a lot of times when we're talking about traumas. So how did this happen? Is it a stress fracture? Is it a fall from standing? Is it a trip and fall? Did they fall off of something? So we want to understand exactly how the injury happened so that we can have an idea of how bad the results are going to be in the patient. And also, if you're in the ER, then you need to know the mechanism of injury so that you know whether or not the patient is a trauma alert, if they meet criteria for a trauma alert. Okay, another big one we haven't really touched on is infection prevention.
Yeah, I was about to say, but I thought we were gonna add it in the medication.
Yep. Wound care, exactly, yeah. Brandon, that's why I was kind of putting maintain the site. So we don't really know what it looks like. Maybe it's an open fracture for sure. We want to be really careful with an open fracture and help prevent infection. So with open fracture for sure, we're going to give prophylactic antibiotics. Other fractures possibly. So let's go ahead and go over to medication. So antibiotics.
Yeah.
Analgesics. And maybe Flexeril.
Yep.
Do we
muscle.
need to get the blood thinner as well?
No.
Possibly.
Because if the patient is on the bed, in bed rest, like a hip broken
Yeah.
or something.
I'm going to say it depends on the patient, whether or not we want to do that. What's the overall picture? But yeah, muscle relaxants, they can get muscle spasms, especially with the hip fracture. It can be really painful, so we might give them like a Flexeril for that, exactly.
Professor, for like what do you call it, on top? How about like TB shots and like DP TB shots?
Yeah, exactly. So whenever we have a break in the skin, an injury where bacteria can get in, usually tetanus is found in like dirt, rusty things too, right? A rusty nail. If they're not up to date on their tetanus shot, they're getting a tetanus shot. And how good? Do you guys know how long a tetanus shot is good for?
5 years.
Ideally, it's been within the last 5 years, but it's really good for 10 years. Yeah. But if it hasn't been in the last 5 years and you're in the ER with a break, you're probably getting a tetanus booster. Okay, let's see. I'm going to also put stool softeners if we're concerned about constipation, possibly fluids. Okay. What about therapeutic procedures? What would we?
So OT, I mean PT.
Yeah, over here. So PT. And what does physical therapy do?
Range of motion exercise.
What makes OT different? What does OT do?
OT occupation. So oh God, I'm blanking out right now. Yep. ADLs.
Exactly. Right. So physical therapy is basically improving the movement of the body, and occupational therapy is to, like Brandon said, help improve the ADLs. So do they need an extra assistive device like a grabber so that they don't have to bend down? Do they need something to help them put their shoes on? That's going to be big in our patients with fractures. We don't want them bending over at the waist. So how are they going to put their shoes on? How are they going to do all those things? And that is what helps with. Okay. You can also help teach them about so things like crutches, canes, walkers, that would be under physical therapy, really, to do the teaching with the patient. How to use those correctly to prevent injury. Therapeutic procedures. What are some procedures that we might do?
Casting.
Casting, yeah. Exactly. So casting or splinting. What else?
Surgery sometimes.
Exactly. Sometimes surgery is necessary. maybe debridement, irrigation, fixation of one kind or another, right? Either internal. So what's the difference between internal and external? If my patient has internal fixation, what am I gonna see? I'm not really gonna see anything.
External is like pins and stuff like that, right?
Did you say pens?
So external is pins and like all those extra pins.
Exactly. Right. Exactly. So if we have internal fixation, we're going to see that hardware on an X-ray, but we're not going to see that from the outside.
Mm-hmm.
External fixation is going to be your pens, your halo devices, those type of things to keep everything lined up. So basically, overall with fracture, what we want to do is line everything back up, stabilize it, and let it heal. So however that needs to take place, depending on the injury, is what we're going to be focused on. Traction is another way that we can help align a fracture and keep it aligned. And traction seems really scary and it seems like it would be really uncomfortable, but traction puts the bone back in alignment, which really helps actually ease the patient's pain. And then what situation do we take the traction off? What if we want to give them a bath?
Spine.
I'm sorry?
So if they have spine issues, we'll have to take it out?
No, I'm talking about traction. If you have a patient in traction.
We just hang it up.
So really, we are not going to remove the traction unless it's an emergency. Okay, so all the things that we're going to do, we're going to keep the traction on. Because that's holding the patient's bone and alignment, and so we don't want to undo that, okay? If they're coding and we've got to move it out of the way, then we're going to move it. But other than that, we don't, unless we have an order, the doctor's there, something like that. Okay, let's go. What about, what other education pieces?
Signs of infection?
Yeah, that's great. So anything they need to watch out for when they go home. So that's always going to be
a fever.
Yeah, that would be a sign of infection for sure. So whenever we're going to send a patient home with discharge instructions, we're always going to let them know what they need to know. What would be something that would bring them back, when to call, when to come to the ER, that type of thing is going to be explained to them when they're discharged. We might do pre or post-op teaching if they had to have surgery. So that's pretty broad. Yep, nutrition is another good one. I put teaching about any kind of immobilization. So that's pins or casts, splints. What do they need to know about those things?
Taking care of them?
Say it again?
You need to know how to take care of them and how to, like, dress them up.
Yeah, that's a really good point. So how to care for them, basically ADLs at home, right? So teach the family
if there's a wound, like a dressing changing.
Yep. Exactly. Okay, good. So complications, we kind of already talked about, so I'll just kind of run down these. So the biggest problem we have is immobility, right? So we have with that the possibility of constipation. So like we said, the patient's immobile, they're probably not eating very well, eating a super healthy diet with roughage and lots of vegetables and fruits. They're on pain medicine. They're probably elderly. They might have an underlying condition on top of the fracture, right? So they might have osteoporosis working against them, or whatever else other health problems they have. So it really is a recipe for constipation. Renal stones, like you guys talked about. Today in sim. So whenever we break a bone, we're going to let calcium loose into the body, into the bloodstream, right? And that can become a renal stone made of calcium. All right, huge one, osteomyelitis. And that's our infection. So if you think about the body and wound healing, right? So if we have a little scratch, no big deal, heals pretty quickly. If we have something deeper, it's going to have to heal by secondary intention and coming up from the bottom, going to take longer, more of a risk of infection. Now think about having an open fracture and you have a break in the skin integrity all the way down to the bone. So we've got the outside layer of our skin, the fat layer, the muscle layer, and we're all the way down to the bone in the body. All that's exposed. So that's a huge, huge risk for infection. So we need to be really, really careful with how we're doing dressing changes, for example, for those patients. And we need to also be giving them their antibiotics, is what we can do in relation to that. And if it gets bad enough of an infection in the bone, they have to have an amputation. So it's really, really important. It's rare, but it can be very, very serious complication. Okay. Compartment syndrome. Talked about. Embolisms. And then just soft tissue damage. So we have an injury at some place in the body. The tissues around it can be injured. We talked about bruising. So we might see some of that as well. We might have a wound that we need to do wound care on. Okay, any questions about fracture? Yeah, I've covered everything. I'm gonna swap, we're gonna do amputation. So what we have is amputation. Right? So amputation, we've got something has come off the body that's not supposed to be off the body. It either happened traumatically or we took it off on purpose, right? So we either have trauma and some ways that, what are some ways that amputation can happen by
Diabetes.
trauma?
It's like a diabetes people.
that's a little bit different. So that would be a reason for a surgical indication. So it's usually due to peripheral vascular disease that's related to diabetes. Car accident, yep, so that's a huge one. MVC. Some type of work injury, like farm equipment, something that large machinery. And then being a soldier, right? So some type of battle injury is going to be a problem or a risk factor, sorry. Okay, and for surgical, we can have diabetes, we can have tumors, osteomyelitis. We just talked about that can be a complication from a fracture. So it just isn't like that. Okay. So if the bone gets too infected, to save the limb, we'll have to amputate it, the infected portion. Thermal injury. Okay, so it's basically the same. So for our trauma, safety measures relating to whatever they're doing. If they're riding a bike, wearing a helmet. If they're on in a car, wearing a seatbelt. Whatever we can do to help prevent trauma, again, is going to help prevent amputation. As far as like Samaya was talking about, the diabetes is a huge one that we see. Yes, for sure, OT is huge. Diabetes is a huge one that we see. Patients coming in and their limb is usually in their feet, and it's black. And so basically it's just lost blood flow to the area. They can't feel it because of the peripheral neuropathy. And so that's why you always teach diabetics to check their feet because they might not feel if there's an injury. And a small injury can turn into a huge wound that can turn into an amputation. So they really need to take care of their feet. Okay, so managing the underlying disease process, whatever is causing the PVD, if it's just a vascular issue or if they have diabetes, managing the foot care. Okay. So our risk factors, trauma, right? If you have a trauma, you're at risk for an amputation. You have underlying disease. Exactly. So diabetes, vascular disease. Expected findings. I thought this was a hard question for this one. So I just wanted to probably with it this time. So what we're going to expect, because obviously we expect that the limb is gone, right? So, or something's been detached. So we expect that it's going to be a relief of the underlying problem if it's pathologic, or care of the limb if it's not. Hold on. Laboratory test depends on what's going on, right? We kind of got two different things that we're talking about, a trauma or a disease process with diabetes. So our labs are going to look differently based on what's going on with the patient. Trauma, of course, we're going to be focusing on CBC. Are they hemorrhaging from anywhere? What else is going on with them? We're going to get a full set of labs just to check everything out. But if they come in, their foot's black, we're going to kind of go a different way with it. We're probably still going to get a CBC. We want to see what their white blood cells look like. We're going to check their sugar, their underlying chemistry as well. We want to know all that before we take them to surgery. Any other pre-op labs that we need to get. So it really kind of depends on the situation, but those are some examples of labs that you might see. Diagnostic procedures is basically going to be focused on the vascular system. So we want to know, is there any circulation in that area at all? And so the different ways we can check that. That's a good question. So if it's bad enough to be amputated, it's usually looking black from the ones that I've seen. We had a patient in the ER one time. Whoever spent any time in the ER, the ambulance will call in what the patient's complaint is, and sometimes it's like what they tell you sounds like no big deal and it is a big deal, or they make it sound like a big deal and it's not a big deal. Well, this time they told us that the patient called out the ambulance because their toenail came off. Okay, so we're expecting not a big deal. And when we pull this sheet back, no, the toenail came off, the toe came off, like the whole toe came off because it was black. So that was an incident where they did not get all of the necessary information, right? Yeah, real life story.
Mm-hmm.
We have enough tissue death. Yep, exactly. Or like we were talking about in osteomyelitis, if the bone is just too infected and we can't get it under control, they might have to have an amputation at that point. That'd be another indication. But yeah, you'll see tissue necrosis, and it does this black color and gets gangrenous and smells really bad. So it needs to come off. Or why it needs to come off is because it will spread up. So also, frostbite's kind of like a different disease process, but I guess it's similar, because with frostbite you're going to have decreased blood flow to the extremities and tissue death, and so possibly, not in Texas, but possibly you could get frostbite so bad that they would have to take the damaged portions off. So tests for circulations that we can do. So Doppler flow, and we talked about that last time when we were talking about DVTs and how we check for that. So Doppler flow is that, or no, that we were talking about that after the test. We're looking at the flow through the vascular system, and it shows you colors and it shows you where it's perfusing and how well it's perfusing. So that lets us know how good is the circulation to the area. And arteriography is going to be a test that's going to show us with dye what the artery vasculature looks like. And same thing can also graph the veins and see what they look like with contrast. All right. So safety considerations. If we have an amputation, we're going to be thinking fall risk. If it's a leg, if it's an arm, we're not so much of a fall risk, right? Or a finger or something like that.
How about
Something
infection?
here. Oh yeah, go ahead.
Infection?
Infection, yeah.
How about like a psych consult for the patient?
Yep. I'm gonna put that down here. So grieving that limb, psychosocial, depression, really it's the grief process. So dealing with the fact that that limb isn't there anymore, body image problems, being able to accept that things have changed. Another big one. So neurovascular compromise, so just like our limbs that are fractured, we're going to be really, really careful with the limbs that have an amputation. Most commonly, you're going to see the lower extremities amputated due to diabetic stuff, or if it's a trauma, you're in some kind of military situation, lose a lot of legs from like IEDs. Phantom pain, I put that in the complications. So that's another issue that they deal with, is feeling that phantom pain. So we're going to check the neurovascular integrity. Hemorrhage, if we have an amputation, is something that we're going to be watching for. We're going to be checking our dressing, making sure that we don't have large amounts of blood coming out. Nursing care. We're going to check the skin or the wound. And we're going to care for it. Do range of motion, mobility. What else do you guys think?
Debridement?
What was it?
Debridement?
Yeah, it's possible. I'll put this over here. So it might need to be debrided. I also put therapeutic communication, because this is going to be a big change for them. So we need to be kind of thinking the medical things that we need to do for our patient, but we don't want to forget that there's going to be some psychosocial issues. How could there not be? So obviously we're going to do everything medical that is necessary first, but we're going to be kind of thinking of that in the background. What about medication?
And that antibiotic probably gonna be for sure.
Yeah. Sure. We're gonna have pain meds. It's gonna hurt. We're gonna need to prevent infection. So they're gonna get IV antibiotics for sure. I put, that's a really good one. Antidepressants or just gonna put psychological. That's a good one, Brandon. I didn't think about that one, but yes, that's really important too. Also, guess what? Constipation. So we're going to be watching. We have immobility likely. We're given pain meds. So we're going to do possibly a stool softeners for that. Okay, for education, what are we going to teach our patient?
Nutrition?
The infection sign and symptom.
Yep. Good job, Ed. Possible complication. What to watch out for. One of those.
Care.
Okay, yeah. Self-care at home. Also, contracture prevention. I don't like the way I spell it. Okay, so all this and probably more, but we'll go with that. Interprofessional care, we said at the beginning, OT is going to be huge. Support group, okay, yeah, that's a good idea. Okay. Physical therapy, how to be mobile. How are they going to use any devices? Okay, what other complications? We've got grieving, phantom pain. I'm going to put impaired mobility. Contractures. Yes. You're trying to put your hand up or no? Everybody seems to be. Almost with them. Okay. Yeah, atrophy. I'm not using the muscles. Okay, so that's the main points. And like I said in my announcement last time, I'll share the ones that I did, so you'll have all this. So let's kind of switch gears and let's go to our questions. I do want to wrap up somewhat soon, but I do want to share these because these are good. Okay. So a nurse is developing a plan of care for a client who has a fracture to achieve the outcome of functional healing. To assist in meeting this goal, which of the following nursing interventions is the highest priority? So the first couple things are going to be about fracture, and then we'll go to amputation questions. I think it's D. Brandon thinks A. That's correct. So our main goal with our fracture is that we want to get the limb or wherever the fracture is aligned, and we want it to be immobilized. So we're going to put it back, right? And then we're going to splint it, we're going to cast it, we're going to use hardware to keep it in place as our main goal with fractures. We definitely want to have optimal nutrition and hydration. That's important too. We want to have OT help them with activities of daily living. We're going to do that too. And we do want to provide relief from pain and discomfort. And honestly, A helps us do that when we have that area mobilized and when we have it aligned, that's going to help decrease the pain. But we will also do that. But this is one of those questions where it's like, ooh, all these sound good. I want to do all of these. If I can only pick one, which one am I going to pick? And it's like, well, what do I need to do for a fracture? I need to align it and immobilize it. So I'm going to pick A. Okay, a nurse is assessing a 24-year-old male patient who had a femur fracture in a motorcycle accident last night. The nurse obtains vital signs on admission and again in 2 hours. Which of the following changes in assessment should indicate to the nurse that the client could be developing a serious complication? Okay. A guess for A, a guess for B. So we're going to be the most concerned about this change in vital signs. So we had a respiratory rate of 18. If we have a respiratory rate of 44 times a minute, that's very concerning. 36.6, it was the temperature. It went to 37 Celsius. So 37 Celsius is 98.6 Fahrenheit. So they have a normal temperature. Reflex bradycardia. Possibly. The blood pressure went from a little bit low to normal, so we're not really concerned about that. The heart rate went from normal to normal. So the only one of these are all fine. Our vital signs are going to vary a little bit. Brady is going to be less than 60, 50. Brady
sorry, less than 60. I'm bad.
Yeah.
Oh, I just want to say less than.
Oh, yeah, less than. So we're most concerned about this. Okay, so we have our same patient. He had a motorcycle accident last night. He's scheduled for surgery. So ORIF is open reduction internal fixation. So they're going to open it up. They're going to fixate it internally with hardware. Okay. We're doing our assessment. We notice that the respirations have increased from 18 to 44. So just like our last question said. And we also notice that the patient's restless and we see some axillary petechiae. What complication do we think might be happening with our patient? Guesses. Compartment syndrome, that's a good guess. Think about something that would be related to our respiratory rate. Yep, exactly, Brandon. Fat embolism. So why? Our patient's restless. So whenever we have a patient become restless out of nowhere, we're concerned about hypoxia. One of the craziest things that ever happened to me was I come on shift in the ICU. The day nurse is like, oh, she's so sweet, such an angel, never presses her call button. You're going to have a great night. like, I don't know, a couple hours into the shift, she starts going crazy, trying to climb out of her bed. And I'm like, what the heck is wrong? And she codes. What does she code? Hypoxia. Okay, so be really careful if your patient becomes restless out of nowhere for no reason. And you're seeing a respiratory change in your patient. So 18 a minute, that's normal. 44 a minute, we're starting to have too many breaths a minute, and we're going to start to be having changes in our blood gas. We're going to be blowing off too much CO2. We're start to have other issues. Axillary petechiae is related to intravascular thrombosis, which may or may not be present. You might see this. If you do see it, then that points to a fat embolism. If you don't, that doesn't mean it's not there. Okay, so why this patient, a 24-year-old male patient with a femur fracture in a motorcycle accident, why him? Why is he at particular risk for the complication? Leakage. Kind of, yeah. Loss of blood, good guess. Why is he at risk for a fat embolism? What happened to him?
Maybe cardiovascular, because the fat is going through the blood. And
Good thoughts. So he has a long bone fracture, which is going to place him at increased risk for a fat embolism. Okay. What is the most important intervention for a patient with this complication? So while this is happening, we know it's because of a fat embolism. What is the most important thing that we need to do for him? Yep, exactly. Airway breathing, we got a problem with that. Airway seems fine, but we have a breathing problem now. And so what we need to do is respiratory support. We need to treat the hypoxia. So if supplemental oxygen through nasal cannula or mask isn't working, then we need to do invasive ventilation. So we can do either like a BiPAP, or we can intubate if we really need to support. Okay. So whatever's going on with them, we need to fix this respiratory issue. Okay, a nurse is caring for a client who is post-operative following an open reduction and internal fixation of a fractured femur. Which of the following actions is the most important for the nurse to complete in the post-op period? Oh, I just realized I didn't put letters on these ones. Nothing C. Yeah, exactly. Exactly. So that's going to be, we're post-op, we did an open reduction, internal fixation. What are we most concerned about? The neurovascular checks. We want to make sure that we have good circulation to that area. Okay, so same client, they had their open reduction, internal fixation. They say the pain medications are not helping, as well as they also say there's a decreased sensation in the affected limb. When we do our neurovascular assessment, we note that the affected extremity is swollen, pale, and cool to the touch. Okay, what complication might be happening? Infection, good guess. DVT, good guess. So the key words, hypoxia, not blood flow. Yeah, exactly. That's exactly right. So compartment syndrome. Why are we thinking it's compartment syndrome? They're saying the medication isn't helping. So pain that is disproportionate to the injury, so pain not being relieved by medication or higher than we might expect it to be for the injury, is suspicious for compartment syndrome. Then it's swollen. Okay, so we have edema, which creates pressure. The extremity is pale and cool, so pallor. Remember our P's for compartment syndrome. Decreased sensation or paresthesia. So when we read this question, the things in the stem that were hinting to you what's going on is that the pain medication is not helping. And then on our assessment, there's swelling, there's paleness, it's cool to the touch. All of these here are telling me, pale and cool is telling me blood flow is not great to the area. So in compartment syndrome, what happens is we have edema in the area, it starts to obstruct the circulation, then we have venous occlusion, now we have more edema, which makes it worse, and then we have arterial flow compromised, and then we end up with ischemia and tissue damage. That's kind of how the compartment syndrome progresses and why it does that. So if you can catch it early and when it's starting to be more painful or you're starting to feel some coolness, then it's usually reversible. If we don't say anything and let it go, and we get tissue death, then we have, it's likely not reversible. Okay, so what is the most important intervention for a patient with this complication? So they have compartment syndrome. What is the most important thing that we need to do? Yep. Well, number one, we need to notify the provider immediately because we need to restore circulation to the affected extremity. Can I do that as a nurse? No. So I got to call the provider. We need the surgeon. We need to figure out what we need to do to restore the circulation. Meanwhile, we don't want to elevate the extremity above the heart or apply a cold compress. Why would we not do those things? What would that do to that limb if I like, let's say it's, well, it is our leg, so it's femur. What if I elevate the leg and put a cold compress on it? What's that going to do to it? Exactly. It's going to decrease the blood flow more. Do we want to decrease the blood flow more? No. We definitely don't. We're already having it impaired, right? So we don't want to do anything that could impair it further. And so we're going to have to go for surgical decompression. And if we didn't catch it soon enough, then they might have to amputate. Okay, so it's really important to watch these patients, and neurovascular checks in both, and our fractures and our amputations are really, really important. Okay. A nurse is teaching a client who has a prosthetic limb due to a right below the knee amputation about prosthesis and stump care. Which of the following instructions should the nurse include in the teaching? All things B, D. Another vote for D. Okay, good. I'm glad we did these. So it's going to be C. So we want to make sure when we're putting the limb into the prosthesis that it's completely dry. We don't want any moisture in there because that can create bacterial, fungal growth. Okay, so we don't want it, for A, we don't want it in direct contact with the limb. They're going to wear kind of that sock thing over it so that it's not the stump onto the prosthesis because it can rub. So we don't want to put it directly on top. We can put on a lotion or an oil only if the skin is about to crack. We don't want to do it regularly. We talked about we want to make it dry, and then if the stump becomes irritated from the prosthesis, then they are going to have to take a break from the prosthesis and let that heal, because we don't want to make it worse with further friction. Okay, so it might be a little irritated, that might be expected, but it really shouldn't continue to irritate the stump. Okay. All right, a nurse is caring for a client who's 2 days post-operative following an above-the-knee amputation. Which of the following is an appropriate nursing intervention for this client at this time? Good job. So exactly, we want to have them lie prone. What is prone? That's when you lay on your stomach. We basically want them to do tummy time, okay? So they're going to lay on their stomach for every 3 hours for 20 minutes at a time. Does it have to be that exact? No, it's okay. Unless you have an order for it. But basically the point is we want them to not spend a ton of time sitting up straight. Some sitting up is good, but laying down in the bed is going to be okay. And then lying prone to prevent the contractures, right? So we don't want to elevate the foot of the bed because we don't want to elevate the affected limb. Sitting up is okay, but we don't want them to sit up too much because that's going to decrease blood flow. And then we definitely don't want to elevate the stump on a pillow because that's going to decrease blood flow to it. Okay, we have a client who's post-op. They had a right below the knee amputation. Which of the following findings should the nurse identify as a possible complication? So which one of these is bad? So one of them we don't want, the rest of them we do want. Yep, good job. So we don't want to see edema above the stump dressing. That's letting us know basically it's too tight and we need to rewrap it, okay? Palpable pulse in the right popliteal space. What does that mean? That means, okay, we had it right below the knee amputation, so I can feel a pulse in the popliteal space. That's the back of the knee. That's good, I want that. The client spends more time in bed than a chair. That's okay, we said we want them to sit up, but we don't want them to sit up too much. So I'm not as concerned about that, that's okay. He says he can learn to live with his new look, good. He's starting to talk about it, that's huge. He is starting to get to the acceptance phase of grief, right? So these are all things that are good or okay. Okay, so again, oh, I might have given away. We noticed that there's edema above the stump dressing. Why is this bad? Good guess, but no. Fat. So we don't want increased edema in that limb, okay? It can delay the healing. And then the stump dressing's purpose is to prevent edema, not make the limb edematous, right? So like I said, what should we do next? Take it off, loosen the dressing. Should I leave it off, Mo? Loosen. Replace. Yep, it needs to be rewrapped. Okay. We might want to notify the provider depending on how bad it is. It's not a must, but if we're having issues, we want them to come look at it. they need to come look at it. But rewrapping it, we're going to take that off and rewrap it several times in the day. Okay, how am I going to wrap it? It's time to wrap it now. What, loose? Okay. No clue. You know what, Mo? That's totally fine. Good question. Okay. A different type of dressing? Yes. So we're going to use, well, first of all, we want the limb to be clean and dry, right? We don't want to be wrapping up anything that's not clean and dry underneath a dressing. We want a clean and dry bandage. So if it becomes wet or soiled, we're going to take it off and we're going to use a new one. What the point of the dressing on the stump is to be a compression bandage. So either we're going to wrap like an ACE wrap around it that's going to put pressure on it, or there's actually like a sleeve that we can put on the patient depending on the facility and the materials that you have. The point is we want compression on that limb to decrease the edema, and that's going to help the limb to heal and form so that it can be fitted to a prosthesis. We're going to wrap it figure 8 style. We don't want to make it too tight though. We don't want it to be loose, but we want it to be snug enough that it's providing a little bit of compression. That's going to help relieve pain. It's going to help support that limb and the tissues in the limb, and it's going to help with edema. Okay, and that is its purpose. And that is it. Good guessing. I really appreciate it. Even if you have no idea, that's totally fine. But do you see kind of how we applied that? The next gen NCLEX questions are really similar to that. So when I'm not doing Concordia things, another side gig I have is actually write questions for test companies. So what is now being done is kind of these unfolding case studies. And so, no, it's still multiple choice. But what'll happen is really similar to like the patients that I shared. There'll be like a little introduction about what's going on with the patient. And then they're going to want you to identify something within the question. So kind of like we talked about, why is this patient at risk for this? Or what are some possible complications? Those are kind of the first step. And then guess what? Those complications are going to happen. So you're going to be doing whatever assessment to check to see if complications happen. And then lastly, okay, the complication has happened. We've assessed it. We've identified it. Now, what are we going to do? So it's progressive and it's totally application. So it starts out easy with, kind of just recall things like, what is this? What test would we use? That type of thing. But then it gets you to think more and more. And so I thought we should kind of practice that. So hopefully that was helpful. Have you guys seen questions like that? No? Okay. So yeah, the next gen NCLEX, there's unfolding case study stuff. There's, yeah, Swift River can be. I really don't like Swift River. I fought with that. There were so many glitches in that last semester. I could not even. Hopefully they fixed some of the glitches. But yeah, Brandon, that's basically, someone's kind of giving you a case study, right? And you're like, okay, what's going on with this patient? What am I going to assess? Okay, now that I know that this is my assessment, what am I going to do about it? What nursing interventions? So I think that the system disorder templates are really, really helpful because it's basically breaking it down for you into, okay, what are the nursing interventions that I'm going to do? What are the complications that I'm watching out for? What are the huge safety precautions that I need to think about? So it's helping you organize all of those thoughts so that when we come back in and we're like, okay, what is the complication that you're looking for? You'll know that. Or like, what do I do if that complication happens? Okay, we know what our procedures are that we might have and that we might do for that disease process. So there's some fun questions though. They're like hotspot questions where, or highlight, where you highlight things that are important in the question. So they're a lot more fun to write than multiple choice, but don't be scared of them. Did that help, guys? Was that a helpful session? Okay, awesome. Okay, great. So like I said, I will share all of the things that I